Welcome to The Kick, your expert-led podcast helping you explore and learn everything about getting pregnant, pregnancy, birth and becoming a parent.
On the podcast and our online pregnancy program, Grow My Baby, we share my experience of helping more than 4,000 babies to be born.
And our experience of running a women's health clinic and parenting 4 boys.
We're here to help everyone to feel empowered in pregnancy and birth with real-life practical information.
Welcome everyone, I'm Brigid Maloney.
And I'm obstetrician Dr. Patrick Maloney.
And guess what, Pat? We've got another Q&A.
Nice, I love Q&A.
Good. So we've got a lot of questions to get through. Let's see how we go. And as we usually do, we're going to get straight into it.
Perfect.
Good. Okay.
Let's go.
Pat's fresh off operating this morning and he's got to get back to work and operate more in about half an hour. So we'll see what we can manage. All right, let's start here.
Thanks so much for your podcast. My name's Jess. My question relates to getting pregnant again. I've got an almost 2-year-old girl, but I'm wondering how my history would apply to a next pregnancy. So at my 20-week scan with my first baby, I had a short cervix of 24 millimeters from memory. And I took daily progesterone pessaries up until 35 and 6. When I went into labour, a foot came out and I ended up having an emergency cesarean with her. I guess my question is, if I had that in the first pregnancy, would I be likely to have it again, both the short cervix and a breech baby? Or potentially could that mean I could try for a VBAC? Thank you so much. I'm 35 at the moment, so time is ticking and I'm aware of that. Thank you.
Whoa.
What a great question.
Yeah.
Well done on that first birth and all of that excitement.
And wanting to go again, like that's impressive.
Fantastic. So there's a few parts of the question, aren't there? The first one is about whether cervical shortening runs in subsequent pregnancies, and I think the answer to that is yes. If someone's had cervical shortening, then they would be considered at higher than average risk of it happening again, and that's okay. The outcome for this caller was terrific, wasn't it? She went into a program of cervical surveillance. They watched the cervix carefully, and when it seemed to be getting a bit too short, they used some vaginal progesterones, which certainly helps. And when she did eventually labour, it was right out in the 3rd trimester. The pregnancy didn't go as long as we'd like, but it went pretty long, and that's a terrific outcome. So if we looked at all of the people who had cervical insufficiency, that term that used to be called cervical incompetence, but that
we thankfully got rid of that.
Yeah. The incompetence bit sounded a bit like it might have been like it was the patient's fault. So they replaced it with cervical insufficiency of all the people with that, this is one of the people we'd be least worried about because they've got the condition, but the cervix responded well to progesterone and in fact stayed closed to within a few weeks of the end of the pregnancy. A few weeks of the due date. The worst case scenario, of course, is when the cervix springs open way too early, and the textbook finding of a painless second trimester labour where the cervix just opens, the baby comes out very quickly, and it's way too soon for the baby to survive. So our usual advice to this person would be to 100% be back in surveillance. So she could have some first trimester surveillance of the length of the cervix. They could have a look on a 13-week scan to make sure the baby didn't have any heart or spinal abnormalities and start measuring the cervix nice and early. Do it again at 20 weeks like they did last time as part of that 20-week morphology scan. Nice long cervix, long closed, 4.5 centimetres, great. Or if it's shorter, then we give the progesterones, then we enroll in a cervical surveillance program where we keep on looking, and we want to make sure that it either stabilises or if it's getting properly short, we put in a stitch. Now, would we just put a stitch in this person anyway? Some people might, some people might not. That'd be worth discussing with your care team at the start. In favour of putting in a stitch at the start would be that, yes, this does seem to be a genuine case of short cervix. On the other hand, the outcome last time was extremely good. Yeah. The breech is unrelated, and that's just a bit of bad luck that you had both of those things going on. There probably are a very small number of people who are prone to recurrent breech pregnancies, and it might have something to do with the shape of the uterus. But in the majority of cases, we think it's a new roll of the dice each time. But whether the baby is bum first or head first is mostly fetal behaviour.
Or in this case, foot first.
Yeah, or foot first. Yeah, it's mostly fetal behaviour, and the baby next time doesn't know that the baby last time was breeched. So it's probably in most cases a brand new roll of the dice each time. So let's say, for argument's sake, that the next baby is head first and has been shown to be consistently head first in the third trimester, then VBAC, all things being equal, would definitely be on the table. Yeah.
Good.
And in fact, someone with a cervix that was going to come open a little bit earlier and a little bit faster, theoretically would be an efficient labourer. And as long as there's enough pregnancy under our belt by then, we'd be grateful in a VBAC setting for a cervix that opened quickly.
Yeah.
Yeah.
Good. All right. Well, good luck with your, firstly, getting pregnant and your pregnancy planning. You sound like you're all over it.
If you, like the rest of the world, are watching Euphoria, Mamma Mia has your new obsession. It's called Watch Party, and it's the podcast dedicated entirely to breaking down every episode of the new season. We drop a new episode every week, so you get instant deep dives, hot takes, and superfans unpacking every twist in real time. Search Watch Party wherever you get your podcasts and hit follow so you don't miss a thing.
All right, let's move to this one, Pat.
Hi, Dr. Pat and Brigid. Love your podcast. This is my third time listening for my second pregnancy. I just have a question about skin irritation, specifically on the face. Is that common during pregnancy? I've just hit my second trimester and I have a persistent rash around my mouth area that's raised and dry, which won't go away. And I just wanted to find out if there's anything I can do about it and if it is common or not. Thanks, guys.
You know these people that say pregnancy glow?
Yeah, it's not always like that, is it?
It's not always the case, no.
No. So the glowing pregnant woman is a second trimester phenomenon, somewhere between the spewing and the big proper pregnant lady that's hard to, that everything hurts.
Yeah.
And some people are lucky enough in the second trimester to have a period where they feel unusually well, reasonably energised, and the skin looks good. And that, unfortunately, is not always the case. So this dry, patchy rash is usually one of the great big long list of pregnancy phenomena that it's a list we're familiar with. It's just that not often talked about. So people know about the nausea and vomiting in the first trimester, but I think we've done an ep before about a great big long list. Yeah. So some skin irritation is one of those. And we haven't seen a picture, so without knowing your specific circumstances, it'd be worth speaking to a local doc about whether it could be something else, something treatable. But if it's just part of the pregnancy picture, then few things that can be done. Moisturising might help, something like plain sorbeline cream. A fair bit of putting up with it. If you're reassured that it's a harmless thing, then maybe we'll just leave it alone. And then I've had some people use 1% hydrocortisone cream, like a Dermaid cream, on various dermatitises in pregnancy. And as a cortisone dose goes, it's tiny. Not much of it is absorbed systemically from the skin, and it's generally considered a reasonably safe thing to do.
It is annoying though, you sort of, you don't know how your body's going to react. I remember having a little bit of a dermatitis patch on my cheek during my pregnancies. I can't remember which one, but it's a bit annoying. You think, oh God, what else?
Yeah, what else? Yeah, exactly. But I think it might just settle by itself, and that'd be nice. But is it an indicator of serious underlying disease? Absolutely not. No.
And it just goes to show how long we've been doing the podcast for now. Like, this is her third listen, and she's had 2 pregnancies. So I presumably, like, one was pre-pregnant and then 2 pregnancies, and
It's nice.
and here we are, coming back for the next one. So that's really great. Good luck.
Hi, Bridget and Pat. So my question is, as a first-time mum, I feel really uneducated about birth, and I'm really scared about losing control and advocating for myself in my birthing experience. My fears include things like being pressured into decisions out of fear, like early induction, having my waters broken too soon, unnecessary vaginal checks to see how dilated I am, or being told to push when my body doesn't feel ready. I also worry about them taking the baby out of the room after birth, and I also fear of being pressured into formula or bottle feeding if my baby isn't latching or my milk supply is not coming through. Additionally, I've also heard from many women that husbands don't feel like they lose all sense of power in the birthing experience, and I don't want to be the one answering all the yes or no questions. I want my husband to advocate for me, but I'm worried the medical team will insist that I answer, even though he knows our birth plan. Also, I've been told by my midwife that, this is my birth and I should feel empowered and it's me and my baby. But I feel like when it comes down to it, I will lose control of these decisions as they need to be made quickly. So what are some practical steps I can take to stay empowered, how I can communicate these fears effectively, and how do I create a birth plan that balances my ideal wishes with being prepared for unexpected changes? Thank you. It would be really great if you could answer this, because I don't know why this fear hangs on me heavily.
Yeah,
You can
wow.
just hear the distress right at the end.
I know,
can't
right?
you?
Yeah. So that's somebody who, it seems like the way I listen to that, they're still a fair way off, and a lot of worries have crept in there.
It's like, we can pick the worries, but she seems to have picked all of them.
Yes, yes, that's my concern too. And yeah, it sounds a bit like she's read the big book of worries and not enough of the big book of happiness and good outcomes. So,
And it is hard because, people feel like they need to share their bad outcomes.
yeah, they do tell you that.
And if you look on any social media, it's all about how out of control you can be in the medical system.
Yes.
Which is, problematic. And I know you and I have talked about that tons too.
Yes.
And it really was one of the reasons why we got the psychologist Rebecca Wheeler on, and she did the episodes on tocophobia.
Yeah.
And not saying that this woman has tocophobia, that's not my area to diagnose, but Rebecca did talk about how to cope with common fears and
Yes.
how to not make that part of your only sort of thought pattern when you're thinking about a baby.
Yeah. So definitely there would be something for this caller in that episode, but also it's why we made the podcast in the first place, isn't it? And the Grow My Baby program is because of this exact problem of people seeing, of being so worried about potential problematic outcomes, the loss of control, unnecessary intervention, that they have become distressed by all that worry. And also people feeling blindsided if stuff happens and they need some intervention, which may be perfectly well advised and perfectly sensible and perfectly legitimate. But the woman didn't even know there was such a thing. Yeah. So I think that one of the problems, and we've discussed this before, but one of the problems is that it's easy to think that some of the things that happen because a birth, typically a first birth, is not going according to plan, that some of those things are actually routine. It's easy to think that, but of course they're not. So if we look at caller mentioned the baby being taken away, well, why would we ever do that? If everything had gone well. We don't even involve pediatrics if everything's gone well. So it's reasonably unusual to need a pediatrician who would want to, and they would never want to take a healthy baby out of the room and into the nursery. So that would only have happened in the scenario of there being a problem, and the paediatrician, after discussion with the family, thought that problem was best managed in the nursery, and the family agreed. So vaginal examinations in labour is another one. Recurrent vaginal examinations in labour are rarely necessary if the progress is often going really normally, but are an important part of getting things back on track if the progress is very poor. So we need to remember that some of the things we've heard going on in people's labours are things that went on because there was a problem, not things that went on because they're routine.
Yeah. And I think people hear that, the hospital has a guideline that every 4 hours someone needs to have a vaginal examination. And I suppose there are those protocols out there, Pat.
So it could depend, of course, on what sort of hospital we're in, which care model we're in. But, for example, if someone was coming in and having their third baby and was clearly progressing well, then that woman really doesn't need much at all. And we might have a listen to the fetal heart every now and again, but that's about it. If somebody was having their first baby, it was going very slowly, they were on a syntocinon infusion to try and get the labour back on track, then yes, we would recommend some internal examinations to make sure that the intervention was working. So it's just yet another example of some of the things that we hear about and might get scared of are not part of routine care. They're part of interventions designed to get better outcomes.
One of the biggest things that might be helpful for this caller is for her to have some psychological assistance, seeing a psychologist that works within the perinatal space that can talk her through these issues.
For sure. I think that is a good example. It depends where the fear sits. So if the fear sits as something and we go, God, I hope that doesn't happen to me. Anyway, I'm getting on with my day. Then no. But if it's if the fear is creating recurrent problematic negative thoughts, it's resulting in anxiety and depression, it makes us wish we weren't doing this, those sort of things, then yes, some help from trained professional can definitely be useful. And the last thing, of course, is education.
Yeah.
So caller brought up about she opened with, I don't know enough. Yeah, I don't know enough. So that's what we're here for. That's why we're doing this. Education is what unlocks some of that fear, because we know why an obstetrician might recommend augmentation of labour to make it go faster, or why someone might recommend this or that intervention in a birth. And that allows us to understand it. That unlocks a lot of the fear. If we don't understand what it's for, the patient might be sitting there thinking, this could happen to me at any time for no reason.
Yeah.
Whereas if the patient understands that would only be done in circumstances X, Y, Z, and she's not in circumstances X, Y, Z, then she really has nothing to fear. I think early in the pregnancy, addressing the degree of the anxiety is a great idea. Learning more. There was also one other really interesting thing she said about the partner.
Yeah, about consent.
Yeah. So that is an interesting one. I've come across that a couple of times in my obstetric career, not in my private practice when I know the patients, but in the public ward where I tend to come in if there's a problem, and I don't know the patients until there's some sort of issue. That can be difficult. We want partners to be well educated and good advocates for the labouring woman's well-being. And I think to advocate well, you need to know what you're talking about. So we want to have high levels of knowledge for the partners as well. And we hope that people listen to the podcast together and do the Grow My Baby stuff together. Unfortunately, at the end of the day, if something's being proposed, like a caesarean section or an instrumental birth, we need consent from the patient, from the woman. That's the laws of Australia. That's not something that we can negotiate or
defer to a partner.
Absolutely not.
Yes.
No. So I think the key to that is to give people plenty of time. So as much as possible, and it's not always possible, but as much as possible, if we can see that a problem is coming up, a lot of good obstetrics is picking problems almost before they happen, and not waiting until there's a major drama before we.
And everyone's rushing in the room, which
exactly,
I don't think happens that often, does it?
Well, when we do it well, it shouldn't, because we should be able to see it coming. So, for example, if we think that the progress has been extremely poor and the fetal condition is deteriorating, we need to sort of, I think good obstetrics is to talk to the couple and say, look, here's the problem as I see it. Here are the issues, and here's what happens if we do intervention ABC. Here's what I think would happen if we don't do intervention ABC. But if you give yourself enough time, the consent process, I don't think is terribly difficult. If you rush people, you have made it difficult.
Yeah. And sort of raise the emergency stakes, like that would be very hard for someone that's already anxious to deal with.
Yes, yes. I think it would be difficult for anybody.
Anybody, exactly. Yeah. So, all right, I'm just going to collate it. So first off is education, and here's a plug for the Grow My Baby program. It is every week you get a new piece of information that is current to your week of pregnancy, so you're not getting overwhelmed and you can digest that. And Pat mentions that we love it if your partner's doing it with you, if you've got a partner. It's really important for you both to be on the same page. The second is potentially having seeking out a perinatal psychologist just to go through this pre-birth stage so you can talk through some of those fears and anxieties.
Yep. For anyone where the anxiety is becoming a persistent, pervasive problem, and where's the line? It's individual. You just want to be able to say, am I a little bit worried about how the birth's going to go? Yes, but I'm otherwise totally fine getting on with my life. Well, I guess that's normal. Is this becoming something that is really, really troubling me every day? Am I feeling anxiety? Am I consistently worried about things that probably won't happen to me? That needs some intervention.
The third thing I think is to listen to the tocophobia episode that we did.
Yeah, fascinating.
And we didn't mention it, but maybe the fourth thing is to actively avoid negative stories.
Yes. That is a problem. I think that's part of the problem. Perfectly happy, perfectly good birth stories are pleasant to listen to, but not nearly as riveting as the highly dramatic, problematic ones. And the internet just can't help that. Just can't help over promote the problems.
Yeah. We're sort of attracted to the negative. Yeah.
And the most dramatic problems are the ones that sort of come out of nowhere and as the listener, we have no way of knowing how common that really is. Yeah.
I want to actually say one more thing before we move on, and that is the idea of a perfect birth. And that differs from a practitioner to a patient to begin with.
Absolutely.
Yeah.
But
within a patient cohort, I think that differs as well. So, it's about working out, well, what is a perfect birth?
Yes.
There really isn't a perfect birth.
No, we might start by saying there probably isn't any such thing. But if the perfect birth for an individual is one that is entirely without medical intervention, then that's okay. But if someone else has an idea that if they require or request some medical intervention, that intervention works like a charm and things go on very well from there. I don't see an important difference between those two scenarios in terms of the happiness of the outcome.
Yeah. And some people feel very empowered during or when or if they do have medical intervention, they still feel empowered. Like people often talk about birth needing to feel empowered.
Yes.
I think being empowered I grew a baby and I have a baby that is in my arms. That's very, very empowering when you get on the other side.
Yeah. I know a lot of people have contacted us with stories about their birth not having gone according to plan, but they were able to utilize the high level of education they had about how obstetrics works to feel cool, calm and collected through that birth. And then they describe a birth that was not according to plan by any stretch, but they still felt empowered, healthy. Well, the outcome was good.
Those are the stories that just make me, feel really proud of the work that we do.
I'm Kate Langbrook and I host No Filter. Celeste Barber.
Hi.
Welcome to No Filter.
It's nice to be here.
Yeah, today we're diving into the world of G-Flip.
And your voice has always been such a calming, warm energy. So that's why I tear up, because you're always growing up with you around. So thank you.
Sally Hepworth, what a absolute jewel you are in the crown of artists.
Oh, thank you. This has been lovely.
Today, we're talking to Rosie O'Donnell.
I just want to tell you, this is one of the best interviews I've ever had.
If you love conversations that go deep and stories that stay with you, listen to No Filter. New episodes of No Filter drop every Monday, wherever you get your podcasts.
To be honest.
Me too.
All right, a little bit of a change of pace. We're going to have someone describing her birth now, Pat.
Hi, Brigid and Dr. Pat. Thanks so much for the wonderful resource that is your podcast. Knowledge is power. I have several questions about baby's head shape, posterior positioning and episiotomy. For context, I've had a positive vaginal birth at my local tertiary hospital through the MGP program here in Melbourne. I had a long posterior labour. At the 32-hour mark of experiencing regular painful contractions, I was 7 centimetres and opted for an epidural. I was able to labour on my hands and knees and move around somewhat while remaining on the bed. After another 4 hours, I had a vaginal exam and was informed that I was 10 centimetres, which made me very relieved. The pushing phase was approximately 40 minutes and my baby girl was born at a healthy weight of 4.2 kilos. Towards the end of pushing, her heart rate showed signs of dropping and several medical professionals came into the room, but I could tell that they weren't, stressed and yelling at each other and running around or anything like that. They were just kind of sitting on the sidelines. I opted for my trusted midwife to perform an episiotomy after they sort of gave me a few more contractions to try and get her out. Thankfully, after the episiotomy, my baby popped out like a pea out of a pod. I healed really well from the episiotomy. I barely noticed the stitches. I didn't even take my Peri water bottle spray out of its packet. So the episiotomy and epidural were really positive experiences all around, despite wanting a relatively low intervention birth. My questions are, my baby had a 99th percentile head circumference and did not have any coning. This was noted by some people in the room. I wanted to know, how common is coning and would this have impacted on the duration of the labour? Would posterior positioning have played a part in potential lack of coning? I walked 41 kilometres in the week prior to giving birth. I gave birth at 41 and 4. I felt like I did lots to turn the baby, but to no avail. She seemed like she was really happy in that position. Is there anything I can do to get an anterior positioning or to help for, optimal positioning in a potential subsequent pregnancy? I'm so excited to give birth again, as it was the most epic, mind-blowing experience. However, my preference would be for it to go a bit quicker, if I'm being quite honest with you. Thanks.
There you go. Well, I hope our previous caller listens to her story because, she wanted a no intervention and it got some intervention.
Yeah. But this is exactly what we're talking about.
Yeah.
Here's somebody who has utilised a bit of intervention very wisely, I think, and has had a cracking outcome. It's fantastic. When I say a cracking outcome, a woman has baby. That shouldn't be headline news, but someone labouring for that long, posterior,
4.2 kilo baby.
4.2 kilo baby, to get that baby out vaginally with minimal assistance is a terrific outcome.
First birth as well. Yeah.
So let's take the story out apart a little bit. My favourite bit's at the end when she said I wouldn't mind it being a bit quicker.
We're with you.
Fair enough. Right on. Yeah. So look, we've discussed this before, but the use of an epi at that stage, poor old epis get a bit of bad press from time to time. It'll slow your labour down. This labour couldn't have been much slower if we tried. And that epi has actually increased this woman's chances of having a vaginal birth. Quite apart from, depending on what you read, that statement might be radical. But an epi in this circumstance has undoubtedly increased this patient's chance of having a vaginal birth because after all of that time with an OP, baby looking up instead of down, labour still only 7 centimetres, which is okay, but we need more. Then the epi has really helped that to happen. It's also doubtless helped this woman regroup after such a long labour and put some energy back in the tank for what sounds like an epic pushing phase. Yeah. So kudos for looking at an epi at that stage. That was a wise decision, I think. And it's not an easy decision for someone to make if their whole plan was never to do that. But here we are. This is not the labour we asked for. It's the labour that we're having. And so we try and make some good decisions. That was one of them. Sure enough, that worked. The woman progressed nicely to full dilatation over the next few hours. Still OP though. And so occasionally you can push a baby out looking up at the ceiling. If you're lying on your back, then an OP baby would come out looking at the ceiling, and that is it's hard to do. They don't really fit out that way, but occasionally they will. It takes a long time. So in the pushing phase, what we hope is that the face rotates and looks down the floor. In that position, the chin will tuck in and a smaller diameter of the fetal head will be presented to the vaginal outlet, and the baby will come out. What happened next sounds like she got to full dilatation, probably head on view, and there was some concerns about decreasing fetal heart rate during pushing, doubtless. There's a lot of compression on the fetal head at this stage. Sometimes there's compression on the cord, and the fetal heart rate can decelerate at that point in a way that is not always dangerous, but can be problematic if it goes on and on and on for a long time. Babies, just like us, they get tired. So there are a number of different interventions that can be done at that time, and this woman, in conjunction with her carers, decided to have an episiotomy just to make the vaginal opening a little larger, and bingo, out came the baby. So there was nothing wrong with her pushing effort. She said that the baby came out like a pea out of a pod, just popped out, and that's because the episiotomy had just made the very last hurdle, which was the perineum being tight. Just created a little bit of extra room. And with a doubtless an almighty push, out came that baby. And then she recovered from that expertly done episiotomy very well. This is the scenario where episiotomies can be extremely useful. They don't do anything if the head's still so far up and we've got a problem with the abnormal fetal heart rate, because you can cut an episiotomy.
There's no pressure on it. There's no baby.
If that's not what's holding the baby back, then that won't work. You can't have an episiotomy if you're not fully dilated, but also the head has to be right down and pushing against the perineum, and you have to be pretty convinced that that's actually what's holding things back. So, again, a wise decision. An intervention that she didn't plan for or think she was going to need, but one that she, in her wisdom, took advice on, and it went extremely well.
All right. So things that she wanted to have some clarity on was the head coning. So no, the baby didn't have any head coning.
The moulding. Yeah, that's interesting. Such a long OP labour, normally there'd be moulding where
they'd be quite squished.
They're like a cone head. Yeah, we call that moulding. And caput, where there's like a sponginess or like a bruise on top of the baby's head from the prolonged labour, and those things are not always seen, I don't think there's any great significance to the fact that they weren't there on this occasion. The baby's head is somewhat designed to fit out, and this baby did fit out eventually.
And it's interesting, isn't it, if she says that other people in the room commented that the baby had no coning. It's so interesting how you remember those things.
Yes. I'm sure the people in the room were mentioning that as a little bit of a medical oddity, but not something that they put any great store by, I'm sure. I don't think it means anything at all for next time. Yeah.
And next time, is she more likely to have a posterior presentation?
Yeah, I think that some people, it's a bit like the breech we discussed before, some people have probably got a shape to their pelvic inlet, to their pelvic floor that might promote OP position, and other time, but that's probably the exception and not the rule. Each time is probably a new roll of the dice. It's mostly fetal behaviour. It's where the baby wants to be. It's presumably where the baby feels right, most comfortable, and it's new roll of the dice each time. One thing's for sure, though, if you've had a previous vaginal birth, it's a whole new ballgame. The problem of being OP is significantly less significant. Significantly less significant.
There we go. That's a statistical term.
It's way less of a worry. Because there's just more room. There's way less resistance on the tissue. And you'll often see someone who's had a previous vaginal birth, the head will descend all the way to the perineum such that you can actually see the hair, and then the baby's hair, and the baby will be looking at the ceiling, and then with one push you just see the head go vroom, and turn around to be looking at the floor. And that's just because there's a bit more room because a big baby's head's come out of that vagina before. So in that scenario, a baby coming down OP, way less of a drama.
And then the final thing that she wanted to know is, would her labour be as long?
Well, the second and subsequent should be shorter anyway if the first baby's born vaginally. So that's on her side. Even if it was OP again, there's every chance that would correct itself and correct itself faster. And let's say there was OP with obstruction. If someone's had a previous vaginal birth, that's typically something we're pretty good at correcting, whereas it can be very hard to correct in someone having their first baby.
And a 4.2 kilo baby, it's likely she'll have another large baby too, is that right?
Yes, well, that might just be genetics.
Yeah. But anyway, thank you so much for calling in and telling us your story. We'd love to get pregnant again and have your baby.
Let us know.
I'm sure we'll still be doing this, so let us know how it all went. We would love to hear. All right, Pat, I'm looking at the clock and you have to go. So that's us for today.
Q&A is always fun.
That's pretty good. We managed to get quite a few in. So we'll be back with another Q&A in about 3 or 4 weeks. But until then, we're back next week. Have a good week. Keep growing those babies and look after yourselves.
Thanks for listening, everybody.
Bye for now. Hey, even though Dr. Pat is, well, a doctor, and we get lots of other doctors and other experts on our podcast, I just need to remind you that this podcast is for informational purposes only. We share lots of medical insights and experience, but everything we talk about is general in nature and may not apply to your specific situation. Please always consult with your own healthcare provider for your individual medical advice when you grow your baby.
Hello, Holly Wainwright here. I'm an executive editor at Mamma Mia, and I have been part of this business, an independent women's media company, for more than a decade now. I have seen a lot, but being independent has always meant that we don't have anyone telling us to play it safe or to avoid the topics that feel a bit too messy or uncomfortable for a boardroom full of dudes to handle. And I never take that for granted. If we help you feel a little bit less alone or more connected through the conversations with fascinating women that Kate Langbrook's having on No Filter or one of our other shows, or if we help you feel more informed with the stories that your group chat is really reading on the Mamma Mia app, please consider, please, becoming a subscriber. Because your support really helps us keep telling the stories that matter to Australian women. As a Mamma Mia subscriber, you get unlimited access to everything. Every article, every video, and every single podcast we make. You can even move with me. Subscribers get full access to our at-home fitness app. including my new weights program launching soon. I promise, with an expert and not just me. Subscribe to Mamma Mia today. Support independent women's media. There's a link to do that in our show notes.